My name's Cory. I'm a preset surgical doctor at the Royal Melbourne Hospital. I'm also a board director with the Australian Indigenous Doctors Association, or AIDA. And today I'm going to talk about what considerations are given to the Indigenous community in terms of perioperative mortality. So we meet today in Melbourne. The traditional name for Melbourne is Naarm. And before beginning the presentation, I'd like to acknowledge the traditional owners of the land, the Wurundjeri people of the Kulin Nations. So today I'm going to talk a little bit about AIDA and who we are, where we work, who we work with, about Indigenous culture and health, cultural safety, and then more about the VASM data, the national data, and where to go from here. So AIDA is the peak body representing Aboriginal and Torres Strait Islander doctors as well as medical students. It's been was first created in 1997 and has two main areas and activities that we're involved in. So the first was initially to support growing the Indigenous medical workforce. So supporting reaching at least population parity of Indigenous doctors is one of our core goals, and we believe that this is critical to an equitable and accessible healthcare system. So just over 35 years since the first Aboriginal and Torres Strait Islander doctor in Australia, we've now got about 450 Aboriginal and Torres Strait Islander identifying doctors, although we need at least 4,700 to reach parity. As far as surgical workforce, we currently have two Australian Indigenous surgeons. We need just over 170 to reach parity. So along the AIDA's journey, we've also expanded our work into advocacy, looking at the inequitable health outcomes seen in Australia. So seen in the rates of chronic and preventable diseases, both communicable and non-communicable. And this is translated into the life expectancy, or known as the gap, the 10-year difference in life expectancy between Indigenous and non-Indigenous Australians. So AIDA works with communities. We work with healthcare services, with research and educational institutions, medical colleges and government. While our work initially began supporting our own doctors and medical students, it has expanded to support our non-Indigenous colleagues, recognising that daily interactions in amongst all healthcare workers with patients, but specifically doctors, without culturally safe interactions, we can't address inequalities that we see in health. So Indigenous culture is inextricably linked with the wellbeing of Indigenous patients and has recently been posed as a newly recognised social determinant of health. Quality healthcare needs to both recognise and be responsive to cultural differences, and account that not all patients have the same cultural norms as ourselves. Of course, this ties into the word no one wants to mention, but racism, and while it's generally recognised that most doctors and healthcare staff aren't racist, there are societal biases that influence our care of patients from all backgrounds, but particularly those from backgrounds that are not similar to our own. In the public health discourse, we refer to these biases as conscious and unconscious, and these greatly affect the quality of our care that we provide patients. So working with health service at any level, AIDA and collectively amongst ourselves, we need to encourage the recognition of the impacts that these biases, as well as the historical racism amongst health services, has and affects Indigenous patients' trust and engagement with health services. Which basically leads us on to AIDA's latest work, which is in cultural safety. So the term cultural safety refers to the accumulation and application of knowledge of Aboriginal and Torres Strait Islander values, principles and norms into everyday practice, but crucially the application of that knowledge. When we talk about cultural imbalance, it refers back to the societal norms that the majority influences in our in doctors and surgeons' evaluation, investigation and care of patients. So it's recognised that there's three, I guess, levels of growth of cultural safety. So beginning with a cultural awareness, recognising that there is a difference, cultural sensitivity, understanding and exploring that difference, and safety integration into everyday practice. So these are some pretty broad and generic examples of how to apply cultural safety, but the points that I'd really like to acknowledge today is practicing acknowledgement of country. So acknowledgement of country is if you are not an Indigenous person from the land that you're on, it's an acknowledgement, whereas a welcome to country is traditionally done by an elder from the country that you're on. And myself as an Indigenous woman, a Gamilaroi woman, started the presentation today with acknowledgement. The second, which sort of leads into why I'm here today, is asking patients if they identify as being Aboriginal or Torres Strait Islander. Recognising the fact that you can't practice culturally safe care if you don't know the background of the patient. And lastly, cultural safety training for all staff. So I recognise that often this question isn't asked by practitioners, surgeons, doctors in the short consultations that we have, and it's often done at registration. It's often done quite poorly. I was walking through pre-admissions clinic the other day and overheard a administrative staff member asking a patient if they were Indigenous by saying, "You're not Indigenous, are you?" Which is the opposite of what we're taught in medical school, to ask open-ended questions. But I guess it's important to recognise that this question needs to be asked in a sensitive manner, in a culturally safe manner, and also recognise that not all Indigenous patients will be dark-skinned, and you can't ascertain somebody's indigeneity by looking at them, and it's quite sensitive given the historical context of stolen generations in this country. Also, I think an important point to make is an explanation why you're asking the question can be really helpful, given as I mentioned before, some of the history in relation to health services being engaged in some of the racist policies in the past. So explaining to the patient why that information is being collected is really important and makes patients feel more comfortable identifying as well. So moving on, close the gap is 3 words that everybody... It is a strategy and represented a political shift in Australia where working with communities was recognised as key to improving Indigenous health, educational outcomes and wellbeing. This is a report from last year, 10 years on from the initial signing. While the review highlighted a number of key changes, it's important to recognise that in some areas, such as in ear health, literacy, high school attainment, there have been large progresses made. However, the 10-year life expectancy gap hasn't seen any improvement. So this is some really interesting data from the ABS. It's quite basic, really, but it looks at, I think it's interesting because it looks at some, perhaps the societal biases we have where we think that Aboriginal and Torres Strait Islander people live rurally and they live in the Northern Territory and not near me, and I don't know any of them, which is sometimes common. I might get asked by somebody, but I don't know any Indigenous people. And anyway, I think this is really important because it highlights the fact that most Indigenous people in Australia actually live in what we call the Eastern Corridor in regional and metropolitan New South Wales and Queensland, and our Indigenous population in Victoria is higher than the national population percentage. So the national population percentage is 3%, and in Victoria it's 7%. So moving on to why I'm here today. So looking at the audit of surgical mortality data from the biennial report in 2016. So this is the part of the form that treating surgeons will be familiar with, but after a perioperative death, we'll get asked whether a patient identifies as Aboriginal and Torres Strait Islander. Okay, so from the report, we know that there were 33,500 closed cases of perioperative deaths, and of these, 419 were deaths of reported deaths of Aboriginal and Torres Strait Islander persons. So while making the assumption that Indigenous patients are as likely to receive surgical care as their non-Indigenous counterparts, to be at population parity, we would expect that number to be in excess of 1,000, which means that over 50% of cases aren't recorded or aren't accurately recorded regarding the indigeneity. This is also assuming that Indigenous patients will have similar rates of perioperative death. If there were inequities in surgical management or mortality, that rate would also be expected to be higher. Importantly, I think it's significant to mention the differences in data collections across states. For instance, in New South Wales, despite having the largest Indigenous population nationally, New South Wales doesn't currently record that information when filling out the form. So there's not a question box regarding whether that patient was Indigenous or not. So we have no way of capturing that information. And also, I guess something to mention is we would suspect a reporting bias as well, that perhaps if a surgeon or registrar is completing the form and the Indigenous status of the patient is not easily accessible or unknown, that people would likely just cross no. So from that data, we know that the Indigenous patients, the 419 we have data on, died at a younger age, had higher rates of serious comorbidities, and the perioperative rate was similar among Indigenous and non-Indigenous patients. So looking at the perioperative deaths, there was a 23-year difference in the median age of death for Aboriginal and Torres Strait Islanders persons compared with non-Indigenous persons. So 55 versus 78. When the patient age was capped at 50 years or younger, and we looked at, and the comorbidities were looked at, there were significant differences in the number of significant comorbidities for Indigenous patients and non-Indigenous patients. And looking at that 23-year difference, we don't know why there is that difference. We don't have the data on that. And that's a really interesting place of exploration. Are Indigenous patients operated on at a younger age? Probably yes, given the age distribution of the Aboriginal and Torres Strait Islander population. Do younger patients have more comorbidities? Yes, we know this. Do Indigenous patients receive different standards in care compared to those who are not? So looking at this slide, we can see that according to the treating surgeon, the clinical management issues, timing of operation is statistically significant difference between Indigenous persons and non-Indigenous persons. Whereas the rest listed there was no statistical significance. So those highlighted there are statistically significant differences between Indigenous and non-Indigenous patients who suffered from a perioperative death. Three that I would like to point out as the most significant issues were communication, treated in a critical care unit, and in self-reflection where the surgeon could have taken a different action. And this is as reported by the treating surgeon. Interestingly, I think communication is one to highlight because this data doesn't break down whether that communication was within the team or with the patient or with the patient's family. And we don't have that data at the moment, and that would be a really interesting area to explore. And I think also highlights the importance of cultural safety training, not just in improving doctor-patient communication, but also even amongst teams as well, recognising that surgical teams, medical teams, allied health teams are made up of people from different backgrounds. When looking at the severity of clinical management issues between the two populations, when there has been a peer review of the case, the areas of consideration and concern were statistically more likely if the patient was Indigenous than non-Indigenous. Just a background of that, an area of consideration is where the assessor believes an area of care could have been improved or different, but recognises that the issue is perhaps debatable, and it represents that a suggestion regarding treatment options or a minor criticism, while an area of concern is where the assessor believes the care should have been better. And just a note on the adverse event part there, just to highlight that an adverse event is not necessarily preventable and may or may not contribute to the death of the patient. For example, in DVT, VTE prophylaxis, a patient can be on the most clinically appropriate VTE prophylaxis and still suffer a pulmonary emboli. So for me, I guess all of this data just leaves me with a lot more questions, perhaps. It highlights some areas where I think really interesting opportunities for RACs, for VASM, for AIDA, for surgeons, students to look at exploring, better understand why there is that 23-year age gap in median surgical mortality, also understand why there are those statistically significant management issues and perioperative deaths, and also looking at the limitations of the data, how we can reduce those by capturing a broader and more comprehensive. And I'd like to acknowledge that this is will be a collaborative effort between all of the people that I've just mentioned, and I don't think any of us can do it solo. And I think individual health practitioners as well, individual surgeons are a big part of that too. Okay. I'd just like to really acknowledge Jess from VASM, who's been really supportive of having me here today and helping me understand a lot of this data. I'd also like to thank RACs as well as acknowledge the data set, the Australian and New Zealand Audit of Surgical Mortality report from 2016, where all of this data is from, as well as the Australian Indigenous Doctors Association, which I'm really proud to be a part of and honoured to be elected to the board there to really work towards this area that I'm